Hello, my name is Annalie Miller, and for my project, I am presenting on the malaria outbreak that occurred in Colombia in 2010. Malaria is a parasitic disease spread by female Anopheles mosquitoes, and there are 5 species of the Plasmodium parasite, including P. vivax, P. falciparum, P. malariae, P. ovale, and P. knowlesi. P. falciparum is the most prevalent around the world, but P. vivax has a wider distribution throughout the world. As a disease, malaria symptoms can range from mild to severe, and individuals can even be asymptomatic. According to the CDC, clinical symptoms occur when the parasite causes the red blood cells to rupture and release hemozoin, a waste substance of the parasite, in addition to other toxic factors that stimulate the body's immune cells to produce cytokines and cause the body to have a fever and rigors. Mild or uncomplicated forms of malaria include a cold stage, hot stage, and lastly a sweating stage, with symptoms that are listed on this slide. The severe form of malaria occurs when the body's organs fail or when the body's blood or metabolism is abnormal. This complicates the infection and can result in cerebral malaria, and that can cause these other symptoms on this slide as well. Malaria occurs more frequently in the tropical and subtropical areas of the world and has the highest prevalence in Africa. However, in the Americas, 5 of the 23 countries account for 91% of the cases there. And Colombia and Brazil are responsible for the greatest amount of cases at 67% of the total in America. Between 2005 and 2009, the worldwide incidence of malaria cases and deaths had decreased from 237 to 222 million cases, and from greater than 800,000 to 691,000 deaths, respectively. In the Americas as a whole, there has also been a decrease in the number of malaria cases from 1.9 million to 1.1 million. Despite the decrease in cases, specifically in Peru, Ecuador, Guatemala, Honduras, El Salvador, Costa Rica, and Panama, uniquely Colombia experienced varying numbers of cases, shifting between 231,000 and 66,000 cases each year. This fluctuation is partially attributed to the geographic and environmental territory, including an altitude of less than 1,600 meters above sea level and preferable temperatures, rainfall, and humidity that promote mosquitoes to thrive here. In addition, Colombia's social, cultural, economic, and political factors are very suitable for transmission. More specifically, armed conflicts, illegal agriculture and mining, social inequality, climate change, and the decentralization of the Colombian National Malaria Control Program, or the NMCP, that has been trying to shift control activities to the Social Security System, or SSS, since 2000. The problem with this shift in control activities is that the SSS has very little malaria technology and operational organization compared to the NMCP. As a result, this investigation was conducted due to the significant lack of reports related to Colombia's malaria situation. Malaria cases reported during 2010 to the Public Health Surveillance System of the National Institute of Health of Colombia were used in this study. A descriptive study was conducted, and case definitions were determined by Civigila, the surveillance system, and included laboratory-confirmed uncomplicated cases, probable cases, severe cases, and complicated cases of malaria. The study considered several variables, including the species of the parasite, the number of uncomplicated and fatal cases, department and municipality of origin, months of consultation, age, gender, type of health, regimen, ethnicity, and time between symptoms and consultation. Database mining was performed, and spreadsheets and Microsoft Excel was used for analysis. Univariate analyses were performed for all of the before-mentioned variables. Other calculations included a Vivax-falciparum ratio, measures of central tendency, for example, mean, median, and mode, and measures of dispersion, for example, range, variance, and standard deviation were also performed. The Annual Parasite Index, or API, was also conducted and related the total number of malaria cases in 2010 with the population at midterm risk for the same year multiplied by 1,000. A chi-square test was used to compare variables with the previous year, and p-values were calculated to evaluate the significance of the data. A total of 117,108 malaria cases were recorded by the surveillance system Civigila, and 66.3% of those cases occurred during the first half of the year in 2010, which was a 32.6 increase from the 78,498 cases in 2009. The p-value for this data was less than 0.001. Therefore, according to this data, in 2010 there was a malaria epidemic. However, it was not clear as to why most of the cases occurred during the first 6 months, which is when the more endemic territories had a dry environment, whereas the second half of the year was when the rainy season occurred. Colombia's territory is divided into 32 departments, also known as states, and 7 departments that make up 27.7% of the population, highlighted in yellow, were identified as high risk, with an annual parasitic index greater than the national average of 10.5 per 1,000 inhabitants. These departments also represented 87.9% of all the malaria cases reported in Colombia, and were therefore high-risk areas. These departments included Antioquia, Choco, Córdoba, Valle, Guaviare, Nariño, and Bolívar. And 5 of the 7, indicated by the arrows, showed an average 44% increase in the number of malaria cases. Plasmodium vivax represented 70.8% of the reported cases, followed by Plasmodium falciparum, representing 28%, and then only a handful of cases by Plasmodium malariae. Mixed infections were also reported, and the reported vivax to falciparum ratio was 2.5 vivax cases for every 1 falciparum case. A greater incidence of malaria cases were found in men versus women, with 64.6 of cases in men and 35.4 of cases in women. Cases had a wide distribution in ages from 1-day-old babies to 101 years old. The median age was 22 years old. The age group 20 to 24 and 25 to 29 represented the highest API for both men and women. However, 30.3% of cases occurred in children under 15 years of age, but greater than 5 years old. This was a surprise compared to endemic regions in Africa and Asia, where children less than 5 years old had higher morbidity and mortality rates. Therefore, in Colombia, more child cases were thought to have resulted from school, neighborhood, or household transmissions. 63% of cases were from rural areas. However, it was concerning that 37% of cases still occurred in urban areas because of the risk of maintaining the transmission of malaria due to higher population densities. The study suggests that this could also be artificially increased because of an improper reporting of case location by patient address to avoid being associated with illegal activities that are occurring in the area. In contrast, urban areas in Colombia are typically also very poor, and these individuals have poor access to health care and educational services. Therefore, this might be more of a reason for their susceptibility in urban areas compared to other countries around the world. The ethnic distribution indicated that about 68.3% of the cases occurred in mestizos and whites, followed by 23.4% in those of African descent, and the remaining in indigenous communities. This distribution did not change much from 2009. In over half of the cases, consultation occurred early within 48 hours. 0.5% of the cases had complications with liver and renal failure being the most frequently reported. Also, 0.02% of cases died. For both complicated and fatal cases, falciparum and vivax were of approximately equal frequency. This makes sense because although falciparum had a smaller prevalence, it is more pathogenic than vivax. More deaths occurred in women who were not pregnant, and surprisingly, 43.5% of deaths had been seen within 48 hours of symptoms. This is believed to be the reason why the percentage of complicated and fatal cases were so low. However, another proposed explanation is because many people were displaced within high-risk endemic areas and were probably already exposed to disease and had acquired some immunity. Unfortunately, the study did not provide an epicurve. For the majority, this outbreak was determined to be the result of a seasonal epidemic transmission as a result of climate changes induced by the El Niño pattern, which according to National Geographic is the abnormal warming of the ocean with changes in the speed and strength of the currents that can occur at 2 to 7 year intervals. It was also attributed to an increase in the population migrating through the high malaria transmission areas because of illegal agriculture and mining. This led to environmental damage that allowed temporary poor housing to be established. There was also community displacement due to the increased presence of legal and rebellious military in these high malaria transmission areas. Although poor agricultural and illegal activities continued throughout 2011 and 2012, there was a notable decrease in malaria cases to approximately 61,000 a year. This is believed to be the result of greater efforts made by Colombia to try and decrease the burden. These efforts included a more timely diagnostic and treatment regimen and the integration of other prevention and control activities between the NMCP and the Global Fund Project. More specifically, the NMCP had targeted its activities on reducing the interaction among vectors, parasites, and human hosts through strategies such as case management. And there was a focus on earlier diagnosis of malaria with an extended diagnostic network of laboratories and microscopists, where most cases were detected with thick blood smears, but there was a growing use of rapid diagnostic tests. The GF project was started in the 5 departments that were at the highest risk for malaria transmission, and they worked on training community workers who were responsible for prevention measures, organizing surveillance strategies, and promoting healthcare access. Because this study was done retrospectively and the outbreak was determined later on, there was no specific treatment plan implemented as a result of these findings at the current time. However, for those that sought care, they would have had a treatment plan based on artemether lumefantrine for P. falciparum and chloroquine and primaquine for P. vivax, as these anti-malarial medications have better sensitivity to their specific parasite species. However, chloroquine-resistant P. vivax has been reported commonly in Southeast Asia and could therefore gain a foothold in Colombia as well, and therefore could pose a future persisting threat. In addition, because P. vivax is the most common disease-causing culprit in the Americas, its potential or dormancy within the liver and capacity for relapse must be considered in Colombia's prevention, treatment, and control programs. Separately, it was noted that there was a lack of timely diagnosis and treatment during this outbreak as a result of administrative issues, including a lack of hiring of microscopists at the time within the NMCP for rural areas. During the time of the outbreak, there were also staffing constraints within the NMCP, causing limitations in routine prevention and control activities due to security concerns emanating from the social conflict that escalated in those areas. The study states the recognition of constraints that arose from using secondary source information with possible notification mistakes, presence of ignored or uncompleted fields, lack of consistency in some variables, misclassification of cases due to errors in diagnosis, poor adherence of case definitions during the surveillance, and errors in digitizing information that could have caused an underestimation of true cases. The study also found that the reluctance of the SSS to take over the responsibility for malaria as a disease and its diagnoses and treatments were currently limiting the quality of data in the country. However, in contrast, the Ministry of Health is working with different information databases, and their studies are being compared to others from different sources, including the individual record services, mortality records, and entomological surveillance data. The Global Fund Project is also leading the community in education, prevention, and control strategies that are more efficient and cost-effective. Lastly, the study states that the Malaria Research Network, sponsored by the Colombian government, and the International Centers of Excellence for Malaria Research, sponsored by the U.S. National Institute of Health, and the NMCP, are working on translating malaria research projects involving Plasmodium vivax responsibility for complicated and fatal cases and the increase in urban transmission. And here are my references. Thank you very much for listening to my presentation, and I hope you found it informative. Thank you.